Hello everyone. In this ECG case, we are discussing that a 65-year-old man presented to the emergency department complaining of severe central chest pain. He is a heavy smoker and history of high blood pressure. The important point here to be noted is he is a heavy smoker and high blood pressure. So both are two important events for a coronary artery disease. Let's check the ECG. Standardization. The calibration of the ECG can be easily be identified by checking the standardization. Two vertical big squares and one horizontal small squares. So this ECG is marked at a rate of 25 millimeter per second. So it is a standard calibration. So next we'll start with the rate of the ECG. In this rate, we should find what are the RR interval and the number of small squares between the RR interval. First, this is the R wave. This is the R wave. So here we can see there are about 22 small squares in this case. When 22 small squares are there, it could be like 22 1500 divided by 22. Okay, 1500 divided by 22, it will become 66 beats per minute. 66 beats per minute. So the rate of the ECG is 66 beats per minute, which is normocardic. So there is no tachy or bradycardia. Check the rhythm. Like is the you check whether the P wave is preceding every QRS complex. Check, yeah, the P waves are preceding the QRS complex. When you're looking at the long lead strip 2, we can see that all the P waves are preceded in the before the QRS. So we can say that this ECG is of a regular rhythm. Okay, next you check the axis. In axis, we check lead 1 and lead AVF. In lead 1 and lead AVF, we could say that lead 1 is positively deflected and lead AVF is also positively deflected. If AVS was negatively deflected, we could have checked the lead 2 whether it is positively deflected or negatively deflected. If it is a lead 2 is positively deflected, it's a normal axis. If it is negative, then it is left axis. Here both 1 and 2 are positively deflected. So it is a normal axis, positive normal axis. So normal axis. What normal axis means? A axis ranging from minus 90 to minus 30 to plus 90 degree. These are the axis which is normal. You check the PR interval. You check the PR interval. You could find here that the PR interval is easily findable. Find like this is the starting of the P wave from here. Then this is the ending of the P wave. So this interval is the PR interval. In the PR interval, we could say it is 4 small squares. The PR interval is 4 small squares. The normal range of this PR interval is 120 to 200 millimeter second. So this is normal here. It is 120 millimeter second, 160 millimeter second, which is normal. You check the QRS complex and the lead to. You check the QRS complex. The QRS complex is, which means that 3 small squares means 0.4 into 3, which become 120 seconds. So the normal level of the QRS complex, we all know what are the normal range of QRS complex. It is less than or equal to 119 millisecond. Okay, so this is normal. Then you check the Q wave, whether any pathological Q waves are seen in this ECG. You check clearly that whether any pathological Q waves are present in this ECG or not. You can see in a V1 there is a small Q wave, but that is not pathological. It's not more than 2 small square or 3 small square. It's just one less than 1 small square. Okay. So this lead 1, the Q wave is very small, deep, not that much deep pathological Q wave. So we could say that that must be disregarded. Okay. Next we are discussing about the no pathological Q wave, no pathological Q wave. Next, we are looking at the P wave. As we all told that it's a regular rhythm with a normal P wave. No particular change or morphology or any duration. The XT segments, where we are checking at the ST segment, you check the lead one. The ST segment is highly elevating, but it is not clearly elevated, but it is starting. You could say that in lead 2, in lead 3, you just see the lead 2, you just see the lead 3, you just see lead 3 AVF, and you see lead 3 V4, V5, and V6. You check this one. All these are elevation. So we see ST segment elevation. Okay, we see ST segment elevation. We see ST segment elevation. ST elevation in lead 2, 3, AVF, also in V4, V5, and V6. These 6 leads are showing an ST segment elevation. Okay, so does any depression is shown in any of the leads? So we should see whether any ST segment depression. Yes, of course, we can see that in V1, this is the ST segment depression. In V2, the ST segment is depressed. In V3, the ST segment is also depressed. So in V1, V2, V3, the ST segment is clearly depressed. Okay, in a lead V1, in V2, and V3, the ST sequence is depressed. You could see any T wave abnormality in the ECG. You check clearly that any T wave abnormality can be observed in the ECG. You check the wave 1, 2, 3, no much problematic in AVR, AVL, any AVF. You see the AVF, V1, V2, and V3. There is a T wave inversion. T wave inversion in V1. The and you see this is a biphasic T wave in V2. Also, there is a biphasic T in V3 also. Okay, you see that you see the T wave. You see that there is a T wave inversion in V1 and biphasic T wave in V2 and V3. Okay, in V2 and V3 there is biphasic T wave. Next, I have noticed AVL. There is a T wave inversion. Sorry, I forgot. There is an AVL also a T wave inversion. I have noticed. So a T wave inversion also noticed in lead AVL. Okay, let's come to the summary. What is the summary of this case? Before summary, you just see the you just see any R wave progression. You see that V3, the R wave is much bigger. The height of R wave is very bigger compared to anywhere else. Okay, so what could we finally diagnose? Which all the lead we get a positive deflections. You see that anterior leads. Okay, anterior leads like you see V1, V2, V3. These got ST segment depression, and you see inferolateral leads. Inferolateral leads like 2, 3, AVF, V5, and V6. It showed a ST segment elevation. Okay, this is the final finding that we have see. You could also see that in R wave, that is a dominant R wave. You see a dominant R wave in V3. See the dominant R wave in V3. The dominant R wave in V3. Okay, so finally we can come to the conclusion that it is a case of inferolateral ST segment elevation MI. It's called Stemi, inferolateral Stemi. Okay, inferolateral Stemi. And why there is a ST segment depression in V1, V2, and V3? Why? Because these are the anterior leads is showing depression with the dominant R wave in V3. We could say that this inferolateral MI has been progressed or just progressed to the posterior part of the heart. Okay, there is progression of the this MI posteriorly also. That is why the anterior lead showing ST segment depression and the dominant and R wave in V3. So if you take a V7, V8, the leads in the posterior side of the heart, you could see the ST segment elevation. So this is a final diagnosis. Okay. Thank you for listening.